Before Shreyas takes his talk, I just want to tell that after the expert viewpoint by Dr. Prema, I would like to take a question with Dr. Namrata and Dr. Minu Matan. So on to you, Shreyas.
So good evening, everyone. I hope my slide is visible. So what I would try to do over the next few minutes, Dr. Charuta extensively covered some of the literature. While my aim would be to not just say that toric IOL can be used in every keratoconic and every post-graft patient, but it is to merely try and highlight where we can use them and what are the factors that we need to keep in mind if we are using a toric IOL in these conditions. Now, we all know a toric IOL is preferably only for orthogonal astigmatism. And what we mean by that is a regular astigmatism in both magnitude as well as direction. That is repeatable measurements even in terms of axis. Now, this is where in patients with keratoconus, it becomes a little bit more challenging. But before broadly saying keratoconus, we also need to delve a little deeper whether the patient has a central cone or a decentered cone, because you are more likely to get a repeatable K reading both in terms of direction and magnitude in a more centered cone than a decentered cone. Was the patient a previous RGP or ROSK user, and are they willing to continue wearing contact lenses after cataract surgery? If that is the case, then the debate ends here, because then monofocal is the answer, because any irregular astigmatism is going to be taken care of by the contact lens itself. But very often in our cataract surgery patients, the diagnosis of keratoconus can also be incidental. That is, they've had a stable keratoconus right from the age of 20. Now they have presented for cataract surgery at 65 or 70. They are not really been bothered extensively by their keratoconus itself, and they've been wearing glasses till a particular age. So these are patients where the cornea can be further optimized and can undergo a cataract surgery. So this is just one such example. These are some of the points which Dr. Charuta had already covered, where she mentioned that poor repeatability and accuracy can be a concern. The ratio between the anterior and posterior cornea is not fixed. And these are things, and where do you measure, whether you're exactly measuring at the vertex or whether you're measuring at the steepest point. All these are the primary reasons why you get variability in measurements. But having said that, if you can optimize the cornea, improve the repeatability of the K reading, it is worthwhile doing so in these patients before taking them up for cataract surgery. This is just another example of a patient who presented for cataract surgery, but incidentally had keratoconus on examination. We first subjected this patient to a topo-guided PRK, and once this cornea regularized and we had a repeatable K reading, we could very safely take them up for a toric IOL implantation. A little more advanced cone, this patient was not interested in wearing contact lenses, had not been wearing contact lenses, had a poor UCVA even before the onset of cataract surgery. Now, this was an opportunity to optimize the surface before going ahead with the cataract surgery. Intracorneal ring segment was done, the amount of astigmatism reduced, the apex flattened. Subsequently, we got a more repeatable K reading, both in terms of magnitude and direction, and then went ahead with the cataract surgery. The video itself is not much, it's just to merely highlight in case a laser cataract is being used post intracorneal ring segments, the edges can cause a diffractive effect, and therefore it's important that you gather the rexus and ensure that it is there are no tags before you go ahead with the cataract surgery. The rest of the surgery is pretty straightforward. So in case this patient is willing to continue contact lenses, like I said, please continue, because if you put in a toric IOL, when you put a contact lens on top of a toric IOL, you'll end up uncovering the astigmatism, and the patient will require glasses on top of the contact lenses to correct whatever cylinder has been induced by the toric IOL. But most of our cataract surgery age group patients are less likely to wear contact lenses in the postoperative period, especially if it's being prescribed to them for the first time. So in these cases, a toric IOL with aiming for a slightly myopic outcome is important, but an adequate counseling is necessary. Again, outcomes are very, very variable. You look at various studies which have looked at it based on the stage of keratoconus, whether any preoperative procedure has been done. Each stage, early stage, you could do a topo-guided PRK. A moderate stage, you could combine it with the intracorneal ring segment. a very advanced stage of keratoconus, you could do a staged procedure, first do a DALK, regularize, and then subsequently go ahead. But each of these patients can be addressed appropriately. PMD is a situation where you have less irregularity in the central cornea, and therefore the K readings are much more repeatable. However, you may have higher degrees of astigmatism and you may require customized toric IOLs. In post-PK and DALK, it's important that we wait till we complete suture removal. It is not necessary that every single suture has to be removed. There might be situations where you've reached an acceptable level of astigmatism. And let's say for this example, this patient for the last 1 year had a stable astigmatism, had 4 to 5 sutures already left in situ, but these sutures were not becoming loose, were not going to disintegrate in the time period, but had developed a steroid-induced cataract. So in these patients, it's better if you remove some of those sutures which are in the opposite axis, you might actually end up increasing the amount of astigmatism. And therefore, it is just better to leave them aside and go ahead with the cataract surgery itself. This is another scenario where a patient post-DALK had also developed a steroid-induced cataract. And as we know, in DALK, the chance of rejection is very less. The long-term survival is very, very good. And these are patients where even higher degrees of astigmatism can be corrected very, very comfortably. So this was a DALK for post-keratoconic patient and had a significant residual astigmatism, almost 9 diopters of astigmatism. And if you implanted a monofocal IOL, even wearing glasses for such a high cylinder would almost be impossible. So the aim here is to really debulk the amount of astigmatism. We are not aiming at emmetropia. This is a customized toric IOL and from the Care Group lens. And this Ultima Smart Toric can correct almost any amount of astigmatism that you require. So by debulking the amount of astigmatism, we are now able to reach a stage that the patient has a very, very acceptable residual error, which they can now wear comfortably with their glasses. So to conclude, toric IOL is a definite possibility, even if the patient has irregular astigmatism. It's important that you meticulously select the case, do a careful planning, optimize the surface before you take them immediately up for a cataract surgery. And again, counseling the patient, explaining to them the purpose of doing a toric IOL in these patients is really to debulk the cylinder, provide a better uncorrected and best corrected visual acuity, whereas we are not aiming for within plus minus 0.5 diopter like we do for our regular set of cataract surgery patients. Thank you so much for your kind attention.
Thanks, Shreyas. That was again another wonderful talk. So let's look forward to what Dr. Prema has to give her expert viewpoint.
Thanks, Chitra. It was a pleasure listening to both Charuta and Shreyas. I would call this actually a debate because the two views were not really, contradictory to each other. I think both of them have actually positioned the two choices that were discussed, the toric IOL and the monofocal IOL. They have positioned them appropriately because there is a place for each. As Shreyas rightly said, if it's in a keratoconus, if it is a central cone, or if you can bring the astigmatism to closer to a more regular astigmatism, then there is just you're actually, the patient would benefit from a toric IOL. Post penetrating keratoplasty and keratoconus are two situations which have something in common, but they are slightly different in another respect. What they have in common is that they both represent situations where the challenge lies in the corneal optics, and you're using the cataract as an opportunity to correct the corneal optical errors. But when you look at irregular astigmatism, we have to understand that it consists of lower order astigmatism, it consists of higher order astigmatism, some amount of coma that presents as astigmatism, some amount of spherical aberration that presents as a defocus. And so there is an interplay and quite a dispersion of various aberrations that interact with each other and result in the visual disability. So to find out how much of that astigmatism is really a refractive, regular astigmatism and how much can be corrected with a lens and how much will remain uncorrected is important. And as Shreyas rightly pointed out, counseling these patients is extremely important. For them to understand, it's not like other cataract surgeries, for them to understand what they can expect and more importantly, what they cannot expect after surgery is an important part of it. These patients would probably go to any cataract surgeon, but it is best to refer them to a place where the corneal diagnostics are available, simply because these patients require a more detailed corneal examination. For a grafted patient, I would look very closely at the graft, and as Charutha pointed out, doing not just a specular microscopy, but to examine, but to know the primary pathology for which the graft was done, for you to be able to predict whether this patient is likely to require another graft in the future. Because if he does, then this entire exercise is futile. These are eyes with already complicated optics, and now you're introducing yet another optical element in the form of an intraocular lens. So while it has the potential of correcting some of those errors, it also runs you also run the risk of complicating the optics still further. So one should be careful about this. Some amount of as I said, interplay between aberrations, like some amount of coma with some amount of astigmatism actually improves vision. But this is more easily demonstrated in an optical bench than in an actual patient. So I think I would say that the way Shreyas has made an algorithmic decision tree about when he would use a toric lens and when he would still opt for a monofocal lens is an important thing. And let's not forget that at the end of the day, contact lenses are always there for post-PK eyes or post-ketoconic eyes to improve the quality of vision. And that's all I have to say.
Yeah, thank you very much. Beautifully summed up, Dr. Prema. I see that Dr. Namrata Sharma is not there. So I think I would, Dr. Nikhil or Dr. Praveen, I would take a question from you. Oh, Namrata is there. Good. Dr. Namrata, now can you tell us, there's a complexity in getting the K value. So do you have a particular go-to instrument to measure the K in a keratoconus patient, or would you like to check it on different devices? How would you do it? I would, since there are other cornea guys here, I thought I could take the thought of Dr. Nikhil or Dr. Praveen, if you all are there. Both of, yes, Dr.
I'm here.
Yeah.
Hi, Chitra, and very nicely summarized by Dr. Prema. But I actually had a question for either of you, Charutha or Shreyas. At what stage, not a cataract surgery, but doing a transplant and then doing a cataract surgery after the transplant? I mean, what kind of case on the scan or on topography will prompt you to do that, to take that approach?
Do the transplant first and then the cataract surgery, you're saying, sir?
Yes.
So predominantly, I would, restrict it to either a dystrophy where the cornea has to be corrected, or advanced keratoconus where the patient is not willing to wear scleral contact lenses in the post-operative period. Probably these are two situations where I would do a graft first, wait for the K reading to stabilize. Of course, all this is keeping in mind that the cataract is not too advanced or you don't have a mature cataract already. But then if it's a relatively early cataract, then the cataract can definitely wait and we can probably do a DALK in these advanced keratoconus, wait for the BCVA to improve, the overall surface to improve, and then consider a cataract surgery. Maybe a year or so after the graft.
Yeah. So as far as the K value measurement, which I'm coming back to again, I know it is a huge challenge in a keratoconus. So if the K is, the cornea is fairly regular within 3 millimeter zone, or would you look at the EKR value, or would you rely on the IOL master? I'm not talking of advanced keratoconus, mild to moderate keratoconus. Which would you look at? The EKR maps, will you trust the IOL master for the K, the pentacam? Shreyas, Charuta, Dr. Meenu Mathan?
Any two
I think-
which are similar to each other. That's what I followed for the first case also, or generally. So
I think it's important to have measurements from 2 or 3 devices, and more importantly, to the extent possible, have repeatable measurements. And of course, the integrated K calculator also can be used, where you have slightly varying values from 3 different devices. Then it gives a certain weightage to each of these values, and gives you the best possible result. Again, these are obviously, like was already mentioned by Prema Madam as well, we are not aiming at absolute refractive accuracy. There is a significant possibility of having some residual error. What could be the best option and how much we can debulk the refractive error is probably what we are discussing.
And just one last question, Dr. Meenu, the formulas which you're looking at, I know we are cataract surgeons and this is so typically a cornea topic. There is this SRKT, which seems to be also popular, surprisingly. And there is this Keynes formula, there's Barrett's formula. Both Namrata and Meenu, just one line answer. Which would be your choice of IOL formula in a keratoconus patient? I had a question for you, Namrata, but it got answered.
Yeah, I got disconnected.
Yeah.
I would use Keynes formula. I think for keratoconus, the Keynes formula is the one which works best. But having said this, we will, like I said, we will use other formulas also. But as per all the studies also, and in practical experience also, I think Keynes is the one which works best for keratoconus.
But why is it that in Keynes formula, I did come across that you take the anterior corneal measurements, but do not consider the posterior corneal measurements values? Is it that we would end up overcorrecting?
So, yeah, because the posterior cornea is going to be much steeper than what it is when you generally would, calculate the power. And even if you look at keratoconus, the only thing is that, I mean, first, this thing that would come, the changes that would happen would be posteriorly. So that would be far more steeper as compared to the anterior part. So that is why
Better to take the
anterior
anterior
part is taken, because otherwise that will fallaciously give you a false clarity.
Yeah. Dr. Meenu?
I don't have comparisons of my own experience. I use only Barrett's right now, but I have to see Keynes also and see whether they're coming different, much different our scenario. But Barrett's is okay working for me for this also.
But I do agree with Shreyas that doing a topo-guided surface regularization also makes sense in these early keratoconus patients. Yes, Dr. Ramamurthy and Dr. Saurabh, we'll be taking your keynote address now. Next. Sorry for the delay. Yes, Dr. Ramamurthy.
Just wanted to add a quick word. If we are considering toric lenses, maybe the Barrett 2K toric formula would be the way to go. Of course, getting the right K readings would be a challenge, as already discussed. Very recently, Barrett has come up with a Barrett keratoconus formula, where specifically addressing the keratoconic eyes. I've heard about it. I've briefly read about it, yet to experience it. Maybe once it gets validated, then maybe that would be the formula you could consider in these eyes.
Thank you.